Andre, what is your personal practice in terms of how you start therapy, in terms of backbone treatment? What are you doing? What combination of drugs?
So for the time being, as practice evolve, we have very much reserve our initial choices to triplet regimens, and our top two triplet regimens which we use are KRD and RVD, and that is
so that
potentially...
would be, just to spell out for the audience what those things
KRD
are.
is for carfilzomib, lenalidomide, dexamethasone, or Kyprolis, Revlimid dex, and then RVD will be lenalidomide, bortezomib dex, or Velcade, Revlimid dex, as commercial names suggest. So this is initial treatment. In our practice, most patients receive KRD.
The same for, what about people who are a bit older and maybe less able to travel? What are you using there?
There is a good bulk of these patients, which in some criteria would be categorized as older and maybe frail, and even distance may be a factor, whom we still offer what we believe is the most active of these regimens based on evidence so far, which is KRD. But there are some patients who have
So you're giving KRD to like 85-year-olds?
I do.
What about you?
You know, I have to say I can see how some patients would be treated that way, but I'm also impressed by how toxic the regimens can be in the very elderly. And it is a challenge, because I think on the one hand you have attention that doctors who pay attention and try to do the best for their doctors, I think that contributes to good long-term outcomes. But then you have to balance that with tolerance by patients. And it's not unusual that I would use milder regimens. In some occasions, even doublets in the very elderly. And I don't think I have the answers for that. That's why I was particularly interested in this session. And I do think we have a gap of knowledge in that patient population.
Mary, the MMRF is sort of tracking through some of your programs what people are receiving around the country. What are you seeing in terms of upfront use in younger and older patients?
We've certainly seen an uptick in triplet regimens in all segments of the patient population, which we think is a good thing, because certainly our data has borne out that triplet regimens are more effective than doublets. But again, if you're dealing with this elderly population, which is more frail, there is a significant number of those patients who are still receiving doublets as well. So.
I think,
go ahead. Yeah.
I think to maybe wrap up this discussion and kind of a balancing convenience, toxicity, and potentially efficacy of the regimen, that is part of the initial discussion with the patient, which eventually is very balanced and eventually helps to select. Your challenging question, 85, probably most of the time I would not use KRD, but I could use for 85 who is fit and who has goal to live as long as possible, a regimen which is the best. So if that surfaces during discussion as primary goal, I want to be in remission as long as possible, I want to prolong my life as much as possible, then the choices are driven by that.
If I could add just something else, there's an abstract, I believe, at this meeting that looked at the data on Aspire and Endeavor and broke it by age groups. And
just since many people might not know what those are.
Of course. So these are two clinical trials, phase 3 trials. One of them compares carfilzomib, lenalidomide, and dexamethasone versus lenalidomide and dexamethasone. Dr. Stewart was a principal investigator for that trial. And the Endeavor was a head-to-head comparison, also phase 3 of carfilzomib, dexamethasone versus bortezomib, dexamethasone. And the point of that abstract is that as you look across the various age groups, the benefit appears to persist. So I think there's a lot of head scratching, because on the one hand, I see those results and I go, of course it matters. We don't want to undertreat patients. On the other hand, you see the importance of fitness, comorbidities, and the toxicity we see every day in the clinic. You have to remember,
to get on the trial in the first place, you have to be relatively fit.
Of course,
right?
that's a very important point that shouldn't be missed.
And actually, many of the trials exclude elderly, unfit patients, so we really don't have good data.
Yeah, and this one, although it's a limited subset, they looked at the patients. I believe the last cutoff was over the age of 75. But you know, it's again that tension between not undertreating and making sure that we balance toxicity.
What about monoclonal antibodies? We're going to talk in a bit about some of the latest data, but have you seen any enthusiasm for those from our patients?
A great deal of enthusiasm. Patients are becoming more and more well-informed, and they're very, very interested in immunotherapy, obviously, because it's such a fantastic area of research right now in oncology. So we're seeing a lot of interest, and many of the education programs we're putting out there around monoclonal antibodies and other immunotherapies are very well attended. So patients know that these therapies are out there, and they're learning about them, and they are asking their physicians about them, which is a great sign.
And have you had the opportunity to use upfront monoclonal antibodies? And
Not as of yet, outside of the clinical trials, but I anticipate we will all be doing that pretty soon. And we'll talk more about value later, but you see the results of something like the Griffin trial that was presented at the ASH meeting, which was a combination of daratumumab plus the standard triplet, RVD, so lenalidomide, bortezomib, and dexamethasone. And at least at that point, the depth of the response is quite impressive. So I don't think it takes a lot of imagination to see the monoclonals being frontline.
what about you? Have you tried monoclonals in the front line yet?
I have, and mostly in the context of clinical trials, but to some extent to maybe answer your prior question with additional comment. So my guide for selecting regimen is in a way helped by what would have been eligibility for a clinical trial. I have those trials, I know what I'm looking for, and if patient would have meet criteria for enrollment into clinical trial, that is then discussed in more detail, but of course that's a possibility. So we have currently two trials with partners antibodies, one KRD plus elotuzumab, and another one is daratumumab. And if patient meets criteria to be enrolled, we've treated patients as old as 80 plus on one of these trials.